Great, I clicked. Hi everybody, I'm hoping that we are now going live for the final session of the day. I'm not entirely sure if I'll get any feedback if you can't hear me, but welcome to this final session. My name is Abigail Perry. I head up the Nutrition Policy Team at the UK Foreign, Commonwealth and Development Office. So we've got a really hopefully inspiring session to finish off today's very detailed discussions. So I'm joined by a number of the panelists who've been on sessions already today. Dr. Steve Collins, Saul Guerrero of UNICEF, Amina Abdulla from Concern Worldwide, Ferew Lemma from the Ministry of Health in Ethiopia, Grace Funnell from UNICEF, and also Zita Prinzo from WHO as well. Very fortunate to have such great brains in the room. So this session is basically starting to ask the question about where we are now, but what now needs to be done. So where do we, in effect, go next? So this is going to be a slightly more informal session. I'm going to throw some questions out to those of you on the panel. So get your brains thinking, great thinkers of the world of CMAM. So Steve, I'm going to throw to you first. Can you just run through a couple of your thoughts on really what are the key barriers or bottlenecks to achieving high coverage for treatment, particularly in fragile contexts? So Steve, over to you.
Thanks, Abby. I suppose the first one I alluded to in my presentation earlier is to move services into the community. You know, try and invest in people and local human resource capacity rather than centres. And particularly, I think we need to look at performance-based incentives to actually incentivize directly community-based workers so that they can treat and implement, say, community case management protocols in the community. The simplified protocols that are being developed, the Compass work and the Mother's MUAC, I think are all part of this, and they will really help. I think the next thing we can do is target better. At the moment, we target based on homogenized geographical data. But there are tools out there to allow spatial targeting, where we can target areas of high burden much more precisely, and we can evaluate the impact of our interventions much more precisely. So to move to a spatial targeting instead of a homogenized geographical targeting. And then thirdly, and I talked about it again, I mean, the cost of IETF, you can't get away from it. It's a real barrier. And, you know, there's been this WHO review that has not moved forward. We're hearing it's not going to allow alternative plant-based recipes. And I think there's a desperate need for more competition in the IETF market. And we need global leadership to help companies engage. You know, people have talked about, Amina talked about engaging the private sector. But at the moment, unless reviews are transparent and they adhere to their own terms of reference, you're going to put barriers into big companies engaging in this market. And I know Saul mentioned that he said that the cost of IETF had decreased. But actually, if you look at the base price, which is the Nutriset price, and you correct it for exchange rates, despite the fact that the market has increased 100-fold, the Nutriset base price in euro has not changed, and they're the ones that are setting the price. And this is because there's not competition in the market. And unless there's a transparent process to review new recipes and to allow those who deal with the recipes, which will be public sector, to present their data, then you're not going to get investment, and we're going to have the same poor competition and maintain of high prices that we have at the moment. So those three things: push services into communities, simplify protocols, target geographic, and have a transparent process for IETF and other nutritional products that actually fosters competition and doesn't put barriers in its way.
Thanks very much, Steve. Just to note that there is a Q&A after these more set questions, so I can already see some questions rolling in. So we'll come back to some of the issues that Steve has raised. I'm going to go next to Grace and then to Zita to cover a follow-on question around dealing with some of the issues around coverage and quality. So I would love to get your thoughts on the adaptations you think have the greatest potential to help us increase coverage and quality of wasting treatment services. So Grace, can I come to you first, and then I'll throw over to Zita for this question.
Yeah, thanks, Abby. I think that's a really great question that I'm sure is on a lot of people's minds. And in looking at the different adaptations, I think the two that are the most, I guess, ready to go to scale, or that we're seeing really an uptake on, is the first is Family MUAC. That is an adaptation that really targets and equips caregivers to be able to better screen their own children. And that is an adaptation that doesn't require a change to any normative guidance. We know that countries are really taking this adaptation and sort of running with it. We saw, and looking at all the adaptations that were also implemented under the context of COVID, this is one of the ones that we saw the most frequently adopted. The next one that I would mention is the scale up of community health workers. While this is being currently reviewed under WHO, it's another one that we know is working. Governments are already looking at this adaptation as a way to really scale up the services and to reach children in their own communities. As Steve mentioned, we need to get closer to the communities. We need to get closer to the homes. And not all countries are waiting for the guidance to be finalized. There are countries that have already changed their national protocols to allow for treatment by community health workers, and we need to keep up with them. We need to ensure that we provide the guidance and that we work to develop training and build the capacity of not just the community health workers, but the systems and all the different aspects that need to be in place to ensure that treatment is possible at the community level. So those are the two that I would say at this point in time are the ones that are ready to go. There are a lot of questions still to be answered. What is the best training package for training mothers? But UNICEF, with our partners and with the different ministries where we're working, we're really looking at how do we answer these questions in the different operational contexts in which they're being implemented. So stay tuned. There's a lot more to come from this space.
Thanks so much, Grace. Zita, can I pass over to you to get your thoughts, given the work that WHO is doing in this area as well? Zita, I can't currently hear you. I'm not sure if you're on mute.
Yes, sorry. Yeah, the question is it the same question on adaptations? Is that the question?
Yes, please. Thank you.
Yes, okay. Well, for maybe before we can answer questions of adaptations, we have to be clear on what the best treatment and prevention recommendations are. So we can't move into the adaptation phase before we are not clear about what the updated recommendations are. So, and I think what we're trying to find out in WHO is we know that not all wasted children are the same. And we're trying to, as mentioned by Jaden, look at risks and risk stratification. I mean, who are the children who need immediate care? And talking of risks such as, we've always talked about wasting, but we should, wasting doesn't come in isolation. It's also, for example, stunting. So, I mean, wasted children who are also stunted might be at higher risk. We're looking into that. We're looking at age. The younger age might be at higher risk as well. And comorbidities, do they have diarrhea or other diseases that might increase the risk? So we need to, we're trying to go away from this emergency mode of a one fit for purpose type of approach. So once we're clear on what children, who are the children who are at highest risk, and what interventions do they need, that's when we can, and WHO has developed the guidelines, that's when we can talk of adaptation. But just more specifically, I think it's extremely important to get more community involvement. So absolutely, involvement of caretakers, the mother MUAC approach is very promising. Involvement of CHVs or CHWs in the treatment. It's one of the questions we're looking at. But if we really want there to be a difference and a reduction or survival, improved survival in wasting, then we really have to involve the community.
Thank you so much, Zita. So having heard from more of the technical angle of this, it would be great to go to Amina to get a bit more of a sense of the operational challenges or areas of priority. So, Amina, from where you're sitting and what you're experiencing, what areas do you think nutrition actors need to focus on and pull together on over the next 5 years at local, country, and indeed at global level to make real progress on the management of acute malnutrition?
Thank you, Abigail. I think there's several areas that as nutrition actors we need to pull together over the next 5 years and even beyond. If I look at what Stephen had said earlier in terms of coverage, coverage at the moment is dismal. So as actors, this is one area that we need to pull together and make sure that, you know, those who need the services actually have access to the services. And this can only be a reality if we address the issue around the cost of commodities. So going back to that earlier discussion on transparency around the reviews and looking at how these commodities can be produced locally and looking at the alternatives and so on. So how do we bring the cost of commodities down? The other area is around prevention. Let's not get the kids to be at a point where they need treatment. Yeah. So how do we galvanize around prevention? It is now an opportune. I mean, we are at an opportune moment around the upcoming Food Systems Summit. The conversation are happening at country level, and hopefully there would be the pre-summit in July. So how do we, you know, look at game-changing ideas that would actually address some of the underlying causes of malnutrition? Yeah. Many countries have strategies, but we have to put money behind those strategies. We have to implement the strategies as they were intended, and there has to be commitment beyond, commitment among the different actors, government, development partners, NGOs who are on the ground and working with communities to implement these strategies. Thirdly is the role, fourth is the role of communities in this whole approach to CMAM. And when we're talking about community engagement, are we looking at the gender aspect of this community engagement? The reality is when we're talking about, you know, engaging caretakers and having them at the forefront of, you know, matters geared towards prevention, but also in the management of the treatment, it's mostly the women. Where are the men? How do we get them more involved in the process? Because, you know, the key decisions around resources that have an impact on prevention strategies, but also in the management of the treatment of acute malnutrition is controlled by the men. So how do we get them in our communities at the center of discussion on management of acute malnutrition, management of waste, of stunting, and in prevention as well? So I think those are some of the areas that as nutrition actors we need to galvanize around, from local level to global level. Of course, each of these has different aspects in terms of level of engagement. And then the whole issue around simplifying the guidelines and allowing for these guidelines, in the case of Kenya, to be decentralized from the facility level to the community where it needs to happen. And this means that we need to look and redefine the role of these very critical healthcare workforce, and that's the community health volunteers, and how that system can be supported. What models do we need to put in place that make it affordable in the end? Because at the moment, it's very much driven by NGOs, and when funding from these NGOs is pulled out, this system almost always collapses. So you get to a point where there's no screening, there's no referral. How do we help these local government to put models that they can afford and still ensure that this critical service is actually available at the community level and is implemented as CMAM was intended to be implemented?
Thank you, Amina. That was great. And it leads me very nicely to Dr. Ferew, and just building on the comments that Amina was making about the role of government from your perspective, and knowing that the Ethiopian government has made a massive leadership role on CMAM. What role would you expect or want governments to be playing increasingly to help in this challenge? But also, what thoughts do you have on the role of NGOs, UN agencies, donors to support this effort? So, Ferew, over to you.
Thank you, Abigail. I think most of the things were stated by Amina, but in terms of I think particularly government, I think there needs to be a big commitment in terms of overall all forms of malnutrition, but focusing on CMAM, I think the government commitments needs to include having a system that takes the CMAM interventions within the existing system, where we are also going to the universal health coverage recommended. So there needs to be a commitment with policies and programs that designed for these. And I think that has been seen in Ethiopia for quite some time, and it's stronger. And with it's even now included within our 10-year essential health care package, which also includes having a CMAM within the system. And I think in terms of our partners, I think we need to come together in terms of what is being globally developed and various recommendations coming up, new things coming up from the global network. But I think locally, the adoption and developing guidelines and continuous capacity development, but also resources for the supply chain, which is not easy, is very important from our development partners, international NGOs. And the other area in terms of the adoption is I think we need to come together to see what works based on what we have at the country level, because it might differ within a country even, as well as across countries, and looking at the conditions and local systems, as I said earlier, will be very important in addressing what we want to reach in terms of saving lives, scaled up throughout the country, and also being cost effective. But on all these, I think we have to focus on, as Amina said, on the prevention side. What could we do to prevent better within this integrated system to have no wasted child in our country? Over.
Thank you so much, Ferew. And I think just to take the opportunity to extend thanks for all of the work that I know that you and many others in the Ethiopian context have done to improve availability of CMAM in Ethiopia. Saul, I'm going to come to you with a final kind of predefined question, but I will welcome comments from others on the panel on this before we move to the Q&A. So big question. So what are we going to need to do to really make sure that we hit the SDG target to get wasting to, I think, less than 3%, a pretty ambitious agenda. So what would be your top 3 things that we need to be doing?
Thanks, Abby. I think number 1, actually try to meet the objective. One thing is to set a target, but you then need to aim in that direction. So I think that it speaks to the importance of having national level targets and measurable commitments to see progress in that regard over the last decade or so. We have seen great progress being achieved once you set a nutrition target and aim for it, as we have done with stunting. So we need to do the same thing for wasting, right? To see wasting, the reduction in wasting being something that we are constantly measuring and tracking progress against on a country by country basis. That I think it's taken for granted that just because there's an SDG that means that we're all focused and working towards meeting it. But I think we need to do much more in that regard where it matters. And that brings me to my second point, which is better targeting. And for me, the first part of that is better macro targeting, meaning, you know, the 3% objective or goal. Today, our ability to really get closer to that is going to be disproportionately affected by whether or not we make progress in certain countries, or, you know, because the problem is not equally distributed, right? So we need to be honest about what those top countries where the prevalence is highest, and whether or not we're making progress there, as opposed to whether we are making progress in areas that right now contribute less towards that global target. And then, as Steve said, absolutely, we need to get better at micro-targeting. The reality is that the problem is also not equally distributed within countries, and we shouldn't be developing policy and practice as if it was. We need to be a lot more targeted about where those pockets within countries where we know the problem is greatest, and therefore where all of our services should be meeting. And third and finally, I think that convergence and concurrence of key essential actions is really essential. Our executive director recently spoke about the importance to not focus on what could be done, but focusing on what must be done, right? It would be great if we could do, 50, 60 different things to improve the lives of these communities and these children. But the reality is that what we absolutely need to ensure right now is that we're doing the 10 or 15 absolutely mission critical things. If we're not doing those mission critical things for those vulnerable populations in those parts of the countries, in those countries that are contributing the most towards the current global prevalence of wasting, we're not really going to make the right progress. So in a way, it's a call for greater prioritization, right? And really being focused on what makes a difference, not what do I do best, what do you do best, is what works best to bring about change, and focusing our efforts, even if it means learning to do things that we haven't been good at doing before, right? We need to be prepared to challenge ourselves to say, we don't know how to do that so well, but we know it's critical to reduce wasting, and we need to learn that new trick. Over.
Thanks, Saul. And I want to throw out a question. I think maybe to, I don't want to put anybody totally on the spot on this one, but maybe to Amina. I just wondered, when it comes to this big challenge of prevention, looking at the context that you're operating in, this prevention is going to be key when it comes to hitting the SDG target. Is there anything you think we're still missing, building on Saul's point? Is there anything that you think is still a really critical challenge that we need to overcome when it comes to the prevention story? Are you still with us, Amina? Might have lost her exactly the awkward point. Amina, are you still with us?
I'm sorry, Abby. There's a bit of a delay, or is it a break in the question? If you don't mind repeating it, please.
I just was wondering if you had any additional thoughts from the context you're working in on what we really need to do to really overcome this barrier around prevention. Prevention is key to hit the SDG target. So beyond the points that Saul has made, is there anything you think we really need to pay particular attention to?
I think one, we need to start from the point of the commitment has to it has to lead to action. It shouldn't be lip service, and leading to action meaning that as a government, and I think the ownership needs to come home. Yeah, as a government, what is it that I am prioritizing to enable me meet the SDG target? And by prioritizing, is the next step would be, how much resources am I willing to allocate? I can only own it if I put in something. Yeah, so starting from the government point of view is, how much am I owning this? And by owning it, it means I'm putting in the resources that are required, or I am committing certain level of resources towards meeting that target. And then there's the accountability element that needs to go all the way down to the communities in terms of how those resources are actually utilized. One of the biggest problems that we have, and this is from where I'm sitting, is that meeting the SDGs has been something that we provide lip service, that we don't put in the required resources, we don't put in the required work to meet the target. And a lot of the times, this part of the world, it is driven by development partners. Not to say that as development partners, we don't have, development partners don't have a responsibility to help or to support countries in meeting these targets, but it should be the country. If it is Kenya, it should be Kenya that is leading, and not just leading by, I mean, symbolically, but leading in every sense of the way, in terms of devising the strategy, but also committing the resources that are required to deliver that. And it's only when we start doing that that we will see sustainable results. Otherwise, it's going to be one project after the other, one project after the other, with no sustainability.
Thank you so much, Amina. So I'm now going to come to the questions that have been raised, or some of the questions that have been raised by the audience today. So just building on this point about sustainability, as Steve and a number of others have flagged so far today, we've got this real dilemma about the cost and production of RUTF. So a question has come in to ask, what can we do to reconcile the high standards for RUTF validation and acceptance by global partners with the need for more local production to increase access and to reduce costs? So hard-hitting first question. Steve, I'm going to come straight to you to get your thoughts on this.
Yeah, no, I think that's a really important and timely question. We have to use common sense. You know, we have the sphere primary indicators of efficacy or effectiveness of CMAM programs, which are recovery, mortality, default, non-response, and coverage. We have those. We can't now start adding other medical indicators that we don't know the significance of. For example, rate of weight gain. As a prerequisite, we can't require recipes to meet every indicator we can possibly think of, even if we don't know the significance of it. We have to be sensible, and we have to look at the main constraints, which are cost of ingredients and availability of local ingredients to local producers. When local producers are dependent on buying animal source ingredients such as milk powder, they invariably in Africa have to import those, and they come from often developed countries. You have to pay for the milk powder up front. You have a 3 or 4 month pipeline to get to the country. You have to manufacture, you have to hold in quarantine for a month, and you have to then wait for a month to get paid. So you're waiting for 6 months for your most expensive ingredient. When you're borrowing on local markets, we were borrowing at 40% interest rates in Malawi. And that just makes it totally non-viable. And so we have to move to plant-based, where local ingredients could be grown locally. And this is talking about integrating with prevention. You know, we're creating demand for local ingredients, where we can push, if we choose the ingredients right, we can push diversity of local agriculture, which will then prevent monocropping and prevent the problems of risk involved with monocropping. And so we can't keep on adding criteria. And ultimately, I'm sorry, I have to say this again, but the review process for these new recipes has to be transparent. It has to follow the protocols as set out, and it can't be prejudged. Otherwise, what happens is that if it's non-transparent and it brings in additional indicators that you suddenly make primary, which never were primary, then it's going to discourage large companies from getting involved, and it's going to block their involvement, it's going to block competition, and it will block investment. And we're in this vicious cycle. So it requires leadership from the top. There's no question about it, that to follow WHO, to follow their own processes and actually not require the perfect to block the good. For example, with the amino acid enhanced plant-based recipe, it's vastly superior in terms of treating anemia and iron deficiency, albeit with a slower recovery rate. Now, the recovery rate means instead of being treated in 40 days, the children recover to the same extent, there's no difference in recovery rate, in 43 days. But the WHO have used that slightly slower recovery rate, they don't know what it means, to not even commission the cost effectiveness review that was a third of the terms of reference for that review, for the overall review. If that non-transparency in blocking carries on, you're going to get the same situation in 20 years where you've got a non-competitive market where one company is dominating and not reducing their price. You know, the UNICEF data, if you look at the Nutriset's price for the last over 10 years, it's been constant in terms of euro. And for sure, the euro has changed according to the dollar, and that's given you your dollar terms cost reduction. But in terms of actual competition, there's been almost no real competition. And so it needs leadership from on top to unlock this and allow competition.
Thanks, Steve. I'm conscious that there are quite a few questions that have come through, but Saul, can I just come to you just to give any reflections on this particular question?
I mean, I think Steve already touched on many of the things that need to be acknowledged, so I don't want to go over the same points. I mean, but what I guess maybe just for context, I think from last year, since last year, about 70% of all the RUTF procured globally has been procured from local producers. So I think that when we talk about the importance of ensuring that there is a level playing field at that level, I would start with the question of in what way isn't there one, right? Because if they weren't able to compete on a global scale, then we would see a much smaller proportion of local producers, generating the products that are procured today. And as I said, I think that we are seeing an increase in the number of local production facilities in program countries, as well as the proportion of overall procurement that comes from those local producers. So sure, there are a range of bottlenecks, and as Steve says, both quality assurance expectations, formula expectations, and investment that is required to get this future for production capacity off the ground continue to be, things that get in the way of even more local production capacity and or a diversification of the local production capacity. But it's not tantamount, those challenges are not tantamount to saying that local production capacity is currently unable to play a significant role in meeting the global demand for this product. It's meeting a significant proportion of, or contributing a significant proportion to the RUTF that is used around the world today. So can it do more? Absolutely. Does that mean that it's not doing enough? I wouldn't say that. I think that it's probably, I think that we need to recognize the overall trend, not just where we are today. Over.
Thanks, Saul. And as I said, I'm conscious that there are other questions, but I did just want to give Zita an opportunity in case I'm conscious that there's been some reference to WHO processes. So Zita, over to you in case there's anything you would like to reflect on.
Well, maybe just to say that, of course, WHO has a process that has been followed also for the guideline on RUTF, looking at the dairy component. We're always very transparent about the process, whether people like it or not. The guideline is going to be published shortly. And I think everyone has to remember that it is a global guideline. So we're not developing guidelines for the various countries or regions. It is a global guideline. And the evidence that we had was just not sufficient to change the global guideline. But we do, of course, the committee and WHO is, of course, extremely supportive of new formulations, whether plant-based or with different commercial amino acid mixes, whatever it is. We are very supportive, and I think there is a need to have various formulations in the market. The call is just to look at these formulations also in other settings, for example, the South Asian setting, where the rate of edema is usually lower than in the Malawi setting, where the trial was done that Steve has been talking about. So in a WHO global guideline, we do have to, since it's global, we have to be clear that it's as effective in different settings. So what we're really advocating for is, I think we need to work together to try to come up with solutions on how we can come up with new formulations. I think we have to look at the way forward, and guidelines, I mean, will be updated as new evidence comes in.
Thanks very much, Zita. I'm going to move now to a slightly different topic. So a question has come in to ask, what can we do more of to leverage maternal, infant and young child programs, nutrition programs, to improve coverage of CMAM? I guess that could go beyond nutrition programs to other health programs as well. Ferew, can I put you on the spot to get your thoughts on how we can make best use of broader health and nutrition programming to improve coverage?
I think that's a good point. And once we have the CMAM program within the existing health system, particularly at the primary healthcare service, it covers all our health extension workers have 16 packages which focuses on maternal and child health, plus CMAM management. So I think that is very important that both the prevention but also the management of nutrition problems are within the health system, particularly in the primary healthcare at community level, so that it will be supported. And what I haven't mentioned before is also we have community agents nowadays. We have mothers who always meet for coffee and tea, the neighbors. So we have a 1 to 5 network of women development army, we call them development army. And they discuss and ask you, how's your baby, how's your husband, but also how they check how the child is. There is a leader who's a good. So these kind of things, engaging communities in terms of including the health services system is quite important. And it includes within the community-based nutrition programs that exist in Ethiopia. So it is possible and it's important to engage the CMAM activities also within the health system and also the nutrition programs that exist. Over.
Thank you very much. The next question starts to get quite specific. I think, Grace, I might try this one with you. There's a question of, in the context of COVID-19, most countries have dropped weight for height, so to prioritise MUAC and edema only, noting that this can exclude some children. And the question is, how can we overcome this challenge in vulnerable communities?
Thanks. Yeah, I think that is a good question. It's a tricky question. And I think the bigger answer to that is that we still need to continue to develop the best tool to use to ensure that we are able to detect these children. Family MUAC tape, weight for height are what is available to us right now. And I think given the context and looking at the different precautions that are taken around COVID, MUAC is just what is the tool that's most easily available and able to use, looking at the different precautions that are needed that are taken under the context of COVID. There's a lot of work that's happening in this area. I think that this pandemic has highlighted that this is an area where we need to do a lot more work.
There's a bit of a follow-on question here, which might be a short one to answer, but to Grace or to Saul. So the question that's come in is, if we go for the simplified nutrition protocols using one product for severe and moderate wasting, who pays for the product? The question actually asks, will it be UNICEF or WFP? I think the reality is that who pays for it is donors and increasingly governments of countries with a high burden of wasting. But Grace or Saul, you want to jump in on the question of who's going to take responsibility in the context of using a simplified nutrition protocol?
Yeah, I'm happy to jump on that. And Abby, you stole my answer, because I was going to say the answer is governments and donors, not the UN agencies. And I think that this isn't just avoiding the sensitivities around the question, is acknowledging the challenges of the past and trying to see this move towards simplifications as an opportunity to also revisit some of the assumptions that have shaped how we have done this in the past. In the future, to the extent, our collective commitment is to see greater domestic resource allocation towards these commodities as they go towards any other essential commodities that are used by a health system. And to the extent that somebody has to cover it, or that is accountable for covering that, ultimately is national governments that are accountable for doing that. I think that what we want to see, and I think that our WFP colleagues would probably agree with, is what is the most efficient and effective way of supporting national governments in doing that, and starting with what makes most sense from an efficiency and effectiveness rather than from a mandate perspective. I think that for us, the way that RUTF is if it was RUTF, the commodity that would be in question, the reality is that RUTF needs to be provided, is considered a medical commodity, and as such, there is all sorts of regulations in country that defines who procures, how that's procured, and the processes that you have to go through for the procurement and distribution of that commodity that we need to factor in. And so the big question is, who is best placed to support a national health system that wants to finance and distribute this particular medical commodity, rather than which UN agency could or has done this in the past.
Thanks very much, Saul. I know this will this debate and discussion will continue over the next couple of days. I've got basically a couple more minutes remaining before we close this session, so I'm going to end with the biggest question, I guess, which is about the potential of the Food Systems Summit in terms of increasing the global dialogue around wasting. I'm not entirely sure from all of the wonderful faces I can see on the screen who would want to take this question. Amina, I promise it's nothing personal, but I know that the Food Systems Summit is meant to be quite a fundamentally country-driven dialogue. So I just wondered, from the perspective of where you're sitting, what role do you see, Amina, the Food Systems Summit playing around this big challenge of wasting? I think every time I ask Amina a question, I manage to create some problem with Amina. Ferew, are you on the line? It would be really interesting to hear from the Ethiopia context, if you've got some perspectives on the opportunities the Food Systems Summit presents in terms of wasting, the wasting dialogue.
Yeah, I think, the Food Systems Summit is, I think, trying to address all forms of malnutrition. Actually, it's trying to address all this. Go on, Amina, sorry.
Ferew, do you want to carry on? Amina, I think we've got a few tech glitches. Ferew, do you want to carry on? Apologies, Amina.
Okay, so I think it's the Food Systems Summit is trying to address the overall SDGs, but I think in terms of talking about the food system, it covers all forms of malnutrition, and I think we're trying to address. In our dialogues, we had one, we are having a second one in 2 weeks, in next week. So I think it needs to be, in terms of addressing wasting, that's one of our focuses, because we have been staying there. We haven't reduced something for the last 10, 15 years, and just reduced recently. So there is a big agenda in terms of working in the food system, focusing on what can be done, starting from household level, and we have these smallholder farmers and others who have these problems also included in these discussions, and the wasting needs to be addressed when addressing the whole what we eat in terms of and who we are. So the food system is actually one of the areas that tries to address all forms of malnutrition, and it should be covered, and we are trying to cover it within Ethiopia. Not specific areas, not yet, we haven't identified, but that's what we have the second dialogue next week for. Over.
That's brilliant to hear. Thank you so much, and thanks to all of the panelists. It's always a real privilege to have people with such experience and such depth of knowledge on this topic to give food for thought and to hopefully set us on our way for the remainder of the conference. We would like just to flag that we were conscious that there have been some technical glitches today, but rest assured that hopefully these are all going to be ironed out. So hopefully tomorrow will be smoother. So that does bring us to the end of today's discussion. So again, many thanks to all of the speakers today and to all of the facilitators, and indeed for everybody who's joined virtually from around the world. So the conference platform will remain open, so please take time to have an explore through what's there. The organisers have got a very eventful and full day for you tomorrow, so please do remember to log on 15 minutes before the session to take your seat virtual and to have your tea and healthy snacks or biscuits ready. So please enjoy the rest of your day, and for those of you who are about to head off to bed, have a good evening, sleep well, and thank you, and see you all tomorrow. Many thanks.
Thank you.